So we'll start with a 2-minute silence and then we'll go straight into the check-in when you're ready. Yeah, cool. So when you're ready, closing your eyes and yeah. Dr. Deepak, when you're ready, opening your eyes. How are you doing today?
I'm all right. Thank you, Jack. Thank you for having me on your pod this morning.
No, it's a pleasure for you to come on. I've been following your work for a while, so I guess what we normally do with this podcast, if we start with a check-in, checking in with similar to what I just asked you, how you're feeling, but also maybe a small introduction into who you are. Are you happy to start?
Absolutely, absolutely.
Yeah.
So, my name is Deepak Ravindran. I'm a physician and a researcher, and I'm a full-time NHS consultant in the field of pain medicine and lifestyle medicine. I work in Reading, Berkshire, and I have got a visiting fellowship at the Reading University and a professorship at the Teesside University. And my passion is talking about the new advances in pain science and communicating that to the public and making people aware that there are so many other ways of managing pain in a much more scientific manner than we've ever been taught in our healthcare schools. And that's been my journey. I've been
Mhm.
uh, from South India, and I was born in Hyderabad, but a Tamilian by birth, and my mother tongue and my parents are from area called Trichy in South India, and did all my schooling and education in India, undergraduation, post graduation, and I came to the UK in 2003. So this marks 21 years of my stay in the UK with now my family and two kids.
Nice, amazing. I guess what I wanted to ask you initially was what made you interested in going to pain medicine? There's so many different areas out there, and I guess pain can be complex. It can be emotionally tiring sometimes. Um, what about pain medicine interested you?
Um, Really good question. Actually, it might be two ways to break this up. I often, when I get asked this, I sort of think about why am why doctor itself, because I am the first and right now still the only person who's gone into the medical field from my mother's side throughout, like, across the generations, uncles, aunts, and then my cousins as well. I'm still the only person in the medical field. And I think a lot of it boils down to probably around seventh or eighth. And back then in India, going into engineering, my father was an engineer. So going into engineering was the pressure that we all felt, come to
Mm.
year eight. That's it. Your studies start for this really important set of engineering colleges called IIT, which is the Indian Institute of Technology. And there were classes that start, just like in the UK, we have this grammar school and 11 plus entrance exams happening. We had that pressure in India to do this training. And it was around that time in year eight that my grandfather fell seriously ill. Not being a drinker himself, never touched a sip of alcohol, he ended up having cirrhosis of the liver. And the default that when people get cirrhosis, which is like a shrinking and a tightening of the liver, and the liver starts to fail, is usually most often associated with people who drank alcohol. But my grandfather never touched a sip of alcohol. He was a very religious man. The only thing was that he probably had tuberculosis and he had TB treatment. And one of the side effects of TB treatment is this liver cirrhosis. And at that time in year eight, I found myself liking biology, being able to explain to my family members what was happening, why my grandfather was feeling unwell, and why this was all happening. And I found myself really enjoying the whole process of knowing biology, being able to explain it to my family members. And that's where the interest for biology came in. And when I told my parents that, nope, I don't want to do engineering, medicine is what I'd like to look at,
Mhm.
that was the start towards going for medicine. I studied in JIPMA, which is a very premier tertiary institute in Pondicherry in South India, where I did my undergraduation. And my post graduation was in anesthesia, pain management, and critical care. So that was my first exposure to a specialty, a post graduation, where anesthesia meant, yes, you could give pain relief and really put everyone to sleep, not just with speaking, but with drugs as well
Mm-hmm.
when you go off for surgeries. But it was there that I discovered the opportunities that are there within specifically pain management, because these are two separate things. With anesthesia, you almost always have good quality drugs that you can get everyone to sleep for. They don't have any consciousness, or at least don't have pain during the time they are undergoing surgery. But chronic pain and pain after the surgery, there were interesting ways of treating it. There were interventions like nerve blocks and medicines. And as a field, I realized at the turn of the century, this was 2000, 2001, when I finished my post graduation, I realized that there was this possibility of doing more research and understanding in pain management and maybe in anesthesia itself. And that's why I came to the UK in 2003 to get my fellowship sort of redid, and my training in Oxford and in London in anesthesia. And that's when my interest in pain management got further consolidated. Almost all pain clinics and pain specialists in the UK or in India, they come from a background of having done their post graduation in the field of anesthesia.
Mm-hmm.
And that is how most of them find their interest in pain management. And a lot of them get interested in pain management because there's also the opportunity of doing injections, blocks. So you can do procedures which almost feel like you're doing a kind of surgery. So there was the excitement and the thrill of doing a block successfully, getting a benefit, seeing the immediate outcome. However, I found that talking to patients, getting that rapport, explaining what was happening, why they are having the pain that doesn't seem to get resolved with nerve blocks or medicines, or where opioids and all these drugs don't work. I found myself channeling the same love that I had in making things simple for my family when my grandfather was unwell. I found that same thing now was required, that there's so much that we don't know about pain medicine. And that's kept my interest to be able to communicate that to the general public at large, to be able to communicate why somebody is in pain when they come to my clinic, because often they come to my clinic. I'm in secondary care, a specialist clinic there. They come to me when the GP can't find out what's happening, when the physio or any other specialist has already seen them, investigated them, yet they are struggling with pain. That's when the referral comes to me. So it's an interesting challenge, but at the same time, there's so much opportunity in making that awareness. And from there, getting some people in a much better place with a variety of opportunities and techniques and treatments that are now available to someone who understands what's happening with chronic pain and acute pain. So that's kind of a slightly longer answer to why pain medicine out of all the fields, but
Mm-hmm.
it is this combination of procedures, narrative,
Mm-hmm.
listening, talking, and then bringing everything together for the patient.
Nice. I'm happy you actually explained that because it makes sense, and it makes sense how actually so much of your childhood has been reflected on your work that you do now in terms of communication, explaining things. And I can assume explaining pain to someone who doesn't understand the body, who doesn't understand injuries, can be very difficult because that person just wants to get rid of their pain and they just see it as one thing, some physical damage, and they want a quick fix. So I guess breaking it down and communicating what the pain is, how it's formed, what they can do, it sounds like it's something you enjoy.
It is. And, a lot of it, Jag, is how society is. We are all growing up and grew up in a society where we've had these preconceived beliefs and notions about what pain is. And most often, people assume that when pain is happening, it must be coming from a structure in the body, and
Hmm.
that there ought to be a scan or an x ray or a blood test that would definitely show what the reason for pain is. Indeed, There's one very interesting research study that I often talk about in my speaking. And this is a study that just came out 2 or 3 years ago, in 2021. It was published, and it was by a group of researchers from Canada and the UK. And what they did was they wanted to find out if people are getting their beliefs about pain from society at large, and maybe one reflection of society is the movies and the digital channels that we are all exposed to, our children are exposed to, these researchers thought, well, how often is pain shown in all the Disney movies, in the Pixar movies, in all the serials that our children watch when when they are there digital, when we give them digital nannies with their
Mm,
iPads and their
yeah.
YouTube channels, and we let them watch that. And these researchers looked at over 50 hours of content and animated movies, asking these questions: how often is pain shown? Is acute pain or chronic pain shown? And which kind of characters, male or female characters, suffer with pain? And the surprising thing they found, that was actually pain was shown very often, sometimes 8 to 9 times an hour on an average. Characters in animated movies or serials on TV were shown to be having some form of pain. But almost always, 90 to 98% of the time, it was acute pain. It was some kind of major trauma on a limb or some kind of injury that results in blood of some kind. And that's what they show. Less than 1% of the time, chronic pain is shown. And more surprisingly, in more than 75% of the time, it was the male character that was shown as having pain. Female characters weren't even shown as having pain. And the fourth point was, most of the time when pain happened, the male characters just kept a stiff upper lip. They wouldn't talk about it. They had to put on a show that they are the
Mm,
man. They can't really show their emotions or ask for help. And if you think about it, one of the thoughts that the researchers put in the paper there is, if this is how we talk about chronic pain to our children, then isn't it any surprise that as they grow up and become adults, their perception of pain is that there's always acute pain, that there's no such thing as chronic pain.
mm,
They may not really believe that women have pain because that's not what they grew up seeing.
mhm,
And the reality, the implicit messaging is, if you have pain, you just get on with it and don't ask for help. And I think those are all very troubling and challenging narratives and beliefs that get soaked into our children and society at large, because
mm,
all of them are false. Chronic pain is more common than acute pain. Women are more prone to chronic pain than men are. And the reality is, patients do need help. It's very difficult to just keep a stiff upper lip, because that really changes the nervous system and the immune system for the worse.
mm. And I guess talking about narratives, from being going from India to the UK, did you see a change in how people perceived pain? Was it any different at all as
It
a
is
whole?
quite different. In some ways, I think our Asian culture and the way there is this, probably two examples I can give is where there is that group of colleagues and friends and other people who come from India as first generation immigrants.
Mhm,
And then you've got the big bunch of Asian migrants who've come in the 60s and 70s, and they have brought up their kids here. They have grown here. They've reached the almost senior citizen state here, and they come to my clinics as well. And the challenge is, with the people who are senior citizens who are coming into the clinic, they are very much of the opinion that pain is very much a structural body thing. And I have to really keep in mind the cultural awareness and the congruence in how I explain to them, how I can gain rapport with that
mhm,
group of senior citizens who come into the clinic asking for help with their pain, because they feel that something has to be done. They have the immense respect for me as a doctor. That is a difference between those who are sort of local here and the people who come from India or from Asian countries in general. But then for the newer generation, the 30, 40-year olds who have been part of India and South Asia's emergence over the last 10, 15 years and awakening, they are much more informed, they are much more aware, but at the same time, they are more insistent that there has got to be a quick fix. And so,
Mm.
for both these groups, culturally, I think they still struggle with the message that now pain is much more complex. There is often a desire very much for them to say, I need to have a fix right now. There needs to be something that can be done that should sort or take away the pain. So I
Mm.
think that's a real dilemma that I still face with our Asian communities across the board. And it's not just about South Asian or South Indian or anything. I think our Asian communities, I find that that messaging has to be much more, almost, I think, at a public health level rather than being one to one.
Mm. And so I guess it's bringing up like scenarios in my head where, like, as a physiotherapist, I work with patients in pain and getting them to, I guess, understand their pain and getting them to a level of acceptance that maybe there isn't a quick fix for this pain, I find very difficult. And I guess I've delved into different things like acceptance and commitment therapy to try and kind of explain pain in different manners. But what have you found from your own personal experience has helped to really cement that message, or is it really actually each patient is different, and you have to tailor your communication towards that patient in different manners?
I think the second part is right. I think I
Yeah.
approach each patient quite differently. But the biggest thing I've found is that if I can establish rapport with them, if I can offer the simple options of active listening and sort of listening to their narrative and their story, then I can at least get them to understand, or at least make that attempt at getting to saying, okay, this is how you can manage pain the new way. In some ways, I almost try to see how I, with my privileged position as a medical physician, can make it easy for my physiotherapy and psychology colleagues, because there's a big challenge with anybody, and I think it's not restricted to the Asian community specifically or the ethnic minorities specifically. I think any person right now, the challenge with sometimes techniques like CBT or ACT is that they are requiring you to have a cognitive flexibility or the ability to rationally explore your thoughts and reject some thoughts or challenge some thoughts and restructure it. That's the fundamental basis of CBT and ACT, is that there is this implicit understanding that it's the person. And if the person changes their thinking, then it will be okay.
Mm.
My biggest issue with that is a lot of times patients come to us with their social determinants of health, the system that they are part of, the community that they are part of, the family unit that they are part of. There is pressure in there. There might be children who have special needs. There might be a relationship challenge with the between the spouse and the spouse themselves. There might be pressures of looking after elderly parents back in the Asian countries or in the UK here. Those are all social determinants of health which will have an impact on the ability of the person to rationally challenge themselves. So, in that situation, if I don't know the whole story of the person and have the rapport to understand the ecosystem that they come from, then I can see why CBT or ACT may be difficult to deploy, because that's really not on the top of their agenda. So I try to find out and assess all that and see if I can stabilize or address or raise awareness of that before actually saying, you know what, I think you'll benefit from a pain management program. I've got my physio or my psychology colleagues. We use a combination of CBT, cognitive behavioral therapy, or ACT, and that will be really helpful for you. But I think there's a lot of work that needs to be done before for setting the stage for them to engage with techniques like ACT and CBT.
Nice. Um, I guess just building rapport, it needs a high level of empathy there. or not high level, but they need some level of empathy where you try and understand where the person is coming from. And I guess when you're in that environment, is empathy something you've built over time? Like as a child, were you quite empathetic? And I guess it sounds like you were, because when you were talking to, I guess, your family members about pain and the illnesses, I guess there needs to be some level of empathy there as well to break down information so that they can understand, and so they're not overly worried or concerned. And
I think so.
yeah.
You know what? Uh, I don't know. I used to read these Linda Goodman. She was an author who wrote all about the sun signs and star signs. And I'm a Piscean. And apparently, Pisceans do make good empathetic creatures, apparently. So I
Okay.
kind of like to think that maybe the empathy is because I'm a Piscean by there. So that's my sort of thought there. But I generally been drawn, I think, even within anesthesia, for example, uh, when I did anesthesia, if you think about it, and for many of your listeners, it's a specialty which really doesn't own any patients. Like we see the patients in the morning who belong to a particular surgeon. So, for example, if I'm going to give an anesthesia to a ENT list, for example, the patients would all be seen by an ENT surgeon. They'll be put for a surgery. I would see these 5, 6 patients in the morning. First time I would meet them, I'd shake their hands. I'd ask the relevant questions about giving them a safe anesthetic. I'd get them off to sleep. I'll see them in the recovery when they've just woken up, and I'll say, "Have you had a good time? Excellent." And that's the end of my interaction with them. Once they leave, I don't ever see them again. I don't ever know them again. And it is just very single, simple, specific episodes. That's it. But I found that I like to engage with people. I wanted to really hear the backstories. And so even
Mm.
when I was doing that brief history taking as part of my anesthetic preparation and giving a good, safe anesthetic, I used to enjoy asking about sometimes about pain, sometimes about their background, sometimes just to understand what is it that makes them tick and say what they do and be who they are. And I think that's what I enjoy in pain management. I think that makes me more comfortable with listening to stories. I'm not all about just doing or giving a pill or giving an injection and getting on to the next one. I really like to listen to that, and I maintain that curiosity and interest. And I think that you could call that as empathy.
Mm.
Maybe that's what it is. But I just enjoy that whole process because those stories are all unique. Those narratives are all unique, and they all form the patchwork that the person is.
Nice. And I guess moving on to your book, Amazon bestseller, is it Pain for Your Mindset?
Thank
What
you.
concepts in that book, I guess, can you speak to our audience today about, in terms of like what is the pain for your mindset? What does that look like? What does that feel like? How can people practice it?
So, just one prelude to that is as a pain consultant, and for many of your listeners who they have struggling with chronic pain, if they've been to an NHS pain clinic or anything like that, I started as a pain consultant in 2010. And for the first 3, 4 years, my biggest skills that I had was that I could block any nerves or do epidurals or do procedures that would give good quality pain relief. That is what I had learned in my fellowship. And then the other thing I was very good at is giving medications, strong medications like opioids, like morphine, other stronger drugs there. So those were my two biggest skills apart from consultation, diagnosis, listening, examining, and arriving at a clear plan. What I did find was that in the 2 or 3 years of doing that by 2014, I was finding that only one third of my patients who'd come to the clinic were actually getting benefit from either the injections or the procedures I was doing. And that also, it was not lasting forever. It was not a cure. It was 3 to 6 months. And then the symptoms would start coming back, which was okay because the NHS was all right for me to repeat the injection again or do another one. But that started becoming a problem. By 2014, the NHS was saying, we won't give money for doing these injections every 3 or 6 months again and again. That's not good value. And they started putting down guidelines and restrictions to say these are low priority procedures, you can't do them. These are poor injections, you can't do them. We started getting evidence that drugs like morphine were having the problem of addiction and they were being dangerous, or it's not recommended in everyone. So all of a sudden, the skills that I had weren't enough for my patients anyway to start with. And then restrictions were coming in with policies and guidelines that meant that what we were giving for patients was neither evidence based or not adequate, and were not helping as well. And that's what made me reflect and think, well, how can I help my patients better? What is happening in the literature to say how should we help people with chronic pain? And when I went about reading through and understanding the literature between 2014 to 2017, looking at what are all the other things that's happening, I realized there's so much that has happened in the field of pain management that I haven't been taught in medical school. I did not even learn it when I was doing anesthesia, and certainly it was not part of my fellowship training. So this is me as a pain specialist finding that there are gaps in my knowledge. Then every other specialist and GP and other healthcare professionals who did not even have pain as their sort of primary field of specialization, they wouldn't even be aware of this knowledge itself. And that's what I realized, that when I was going around talking to GPs or talking to some patients on a one-to-one basis, I was finding that I was repeating some things commonly about what are the other ways of managing pain if drugs and injections are not the answer for everyone. And that really is what has condensed and consolidated into this book, The Pain Free Mindset. It really is a evidence-based summary written in a for the layperson, for the general member of the public. I think the publishers told me that somebody between the ages of 8 to 13 should be able to read it and understand it. So it's pitched at that simple language, explaining all the evidence base that is there for managing pain. And I did not want to throw the baby out with the bathwater. So I did not want to say no drugs and no injections.
Mm.
I think for the right patient at the right time, there is the need for a good quality drug or a good timely injection or surgery or infusion. But for every patient, there is the opportunity to calm the nervous system. And that's something we can go and unwrap it a little bit more about the concept of a sensitized nervous system and immune system. That for calming that system, there is the opportunity for understanding stress management principles in the neuroscience. There is evidence for diet and nutrition to a certain extent. There is huge evidence for addressing sleep, about physical activity, and a variety of mind body techniques, which we always used to call complementary. But I think now that word complementary should not be, they should be essential aspects of pain management. And it is this bringing of almost these seven elements, if you like: medications, interventions, so the M and the I, neuroscience, the N, D is for diet, S is for sleep, E is for exercise and physical activity, and T is for therapies of mind and body. And so that kind of is the
Mm.
mindset, the pain free mindset, the acronym that makes up this book. And then I end with a couple of chapters talking about what's available in the NHS to kind of deploy this already, why there is so much of waiting time right now, and actually what can people do while they are getting ready to see and look after their pain, and how can they manage and understand it. And it's been thankfully received very well, not just by the patients themselves, but also by my colleagues, my pain physician colleagues, my physio colleagues, psychology colleagues, nutrition. So it's been received very well because they can hand it out to their patients and say, here you go, let's read this and then come back. And I think that's been the most gratifying thing for me, is that what I had vaguely in my head of what I was talking to GPs, with the help of Penguin and Random House, we've been able to bring it together, and my editor was able to put together something that everybody likes.
Nice. I guess leading on to that, then can we kind of unpack those things like in terms of stress, sleep, immune system, diet? Like, how do these things play a role in pain in general?
Yeah. The fundamental thing that I would like your listeners to sort of take away is now this understanding or distinction between pain, like the way we think about it, and this new word that has been introduced. Actually, it's not a new word, but it's been around for some time in the research and in the clinical field. But now we want to talk about it in a more general fashion to the public. And that word is nociception. And what I wanted to always bring about is that we've often confused nociception and pain, and that has led us to make wrong decisions. If we understood what these two are, then we can do the right thing and the most appropriate action for a patient. So, nociception as a word is referring to the concept of chemicals that are released at the site when an injury occurs. So, if you have a surgery, if you have a fall, if you have a fracture, if you have a flare up of your rheumatoid arthritis or your Crohn's or your IBS or a heart attack, you get chemicals that are released at the site where the injury is. Those chemicals get converted into electrical signals. That process of chemicals being released and getting converted into electrical signals is called nociception. That by itself does not really reflect the intensity of pain. Those electrical signals then have to travel in the nervous system from whichever part of the body. They will reach the spinal cord in the back near the spine, and then the signal will go up to the brain. The brain will receive this signal, and what the brain now does is it has got lots of pre-existing already stored memories of that particular event or events like that already. And the brain then has to do this kind of processing. It will predict what action it has to take based on the signal that has come, whether such an event has happened in the past at some point or not. And then if it decides that it has got to protect the person, so you see a lot of processing, prediction, thinking, comparing, all of this the brain does in a fraction of a second. And if it decides that it has to protect you, that is when it will bring about the experience of pain. So, nociception and pain are two separate things altogether, and you can have nociception but you need not have pain. So, for example, the soldiers we read about in the war who have their limbs blown off but are able to continue fighting, the sports people who sustain a fracture but then continue finishing the game without feeling any pain. We used to think of that as, oh, these people have high pain threshold. But the science right now suggests that these are examples where you can have nociception, clearly they have injury, but there's something bigger that is going on because there is a bigger threat to life. So the soldier will first need to get themselves or whoever they are protecting to safety first. So pain experience need not come until they reach safety. Then that experience of pain will come for that particular injury. So this is the way. Whereas you might have other situations wherein there will be no nociception at all, but because there is a pre existing memory trace already, the nervous system can bring about the phenomenon of pain and you can have the experience of pain. So, conditions like fibromyalgia or migraine or some episodes of low back pain, IBS, you don't have any injury happening in these patients, but their pain is very real because the nervous system has flared up. And this is the distinction which is very important because when you do have nociception, that is, there is chemicals being released, that's the place that you give an anti-inflammatory drug or you give some strong pain medication, including morphine, it will work the best. If you do a surgery or a nerve block or an infusion or an injection, it will make a difference because you are tackling something there. But for the pain experience, you have to find ways to calm the nervous system signaling that is changing there. The processes in the brain that have set up these algorithms and prediction models. And that's a totally different set of strategies. That is where we have now found that optimizing sleep, reducing stress, changing the nutrition because that changes the immune system, physical activity because that builds new nerve circuits, and mind body techniques, relaxation, mindfulness, yoga, Pilates, all of these change the nerve circuits and dampen the sensitivity. And that is why all those techniques have now become much more popular and more important when you're trying to address the pain experience.
Um, so the few things you touched on there, and I guess the first thing that pops up in my head is for someone listening right now and they feel overwhelmed, um, they don't know what to do, they feel almost helpless, and maybe they've gone and seen another pain consultant, they've been told the same things, they've seen a physio, they've seen a psychologist, and they're 2 weeks down the line, they're trying to implement everything and they're finding it difficult. What practical, simple things should they really be focusing on at that early stage? But if they've been given all this information, to take those steps forward in, I guess, living a better lifestyle and better life.
Great question. Really great question. And that is where I think it's both an opportunity and a challenge. I think it's an opportunity for us as healthcare providers, JAG, to be different and do different. And the challenge for patients is exactly that. This is overwhelming. Suddenly saying, oh my God, I can do this, but what do I do? What should I be doing as the
Yeah.
first step? So, what I tell patients and what I find that is that this has got to be almost at a system level. So, the first thing is, are they ready to change in a sense that have they listened to all this information, but are they living in an ecosystem where that kind of change implementation is very tough for a variety of reasons? And that
Mm,
might be one part there. So, understanding that part of where they are they ready to make those changes? And if they are feeling overwhelmed, what is the reason for the overwhelm? That is important to find out. And we need to help them as healthcare providers, give them that extra bit of time, another consultation to actually say, okay, let's break this down and see what are all the things that are causing overwhelm. And right now, the best evidence seems to point and saying that start with a micro habit. Start with one or two things that are easy to do, simple to do, or things they've already done themselves, and you tag one extra point alongside it.
mm,
Now, this will be varying from person to person, but that is the discussion that we almost need to adopt a coaching stance, somewhat like not a healthcare provider who just prescribes, but we need to have that bit of coaching to actually say, with these four techniques, which technique can you possibly do? And then help them set a small goal and make sure that they have the ecosystem to actually fulfill on that goal. And that, I think, is the responsibility of a healthcare provider to alter themselves. Where I try to make one easy step in terms of behavior change is that if that means that giving them a medication in order for them to feel like they have the confidence to do that one small step, and if they feel that that's what they'd like, whether that's a muscle relaxant, whether that's a pain relief medication, then that's a place wherein I might offer them a temporary quick fix like a drug. But I would very clearly say this is for 2 or 4 or 6 weeks, but this is to enable the rehab. So now let's focus on out of these three things, a sleep strategy or a relaxation technique or a distraction technique or an activity technique, something for flare up. What are the one or two things you do? How small does it need to be? And can you do it successfully? Because if you set something that they fail to do or they can't do, that will just reinforce their hopelessness or feel that, oh my God, I couldn't even do this. So they stop doing everything else. And I think that is the discussion and conversation piece that we as healthcare providers need to have with our patients to give them the first few steps, the first few days, and that's what I try to do in my practice with a lot of patients in terms of, I would say, goal setting, but effectively that coaching stance to help them identify their first steps.
nice. So I guess there's a definitely an element of having someone you can work with, like an accountability almost, whether it be your physio, your consultant, your psychologist, whoever you're working with, having that level of communication and accountability with them, and not try to do this alone.
Absolutely, absolutely. I think,
Mm,
and the evidence is there now. For example, for the last 3 years in my NHS practice, we give questionnaires which the patients have to fill before they come to our pain clinic. One of the questionnaires we give is something called pain self-efficacy questionnaire, which
mm,
essentially just tries to understand how confident they are in looking after themselves. And what's surprising is that when they have chronic pain, so this questionnaire is got 10 questions and it is scored like each question is out of 6. So they
mm,
can score a maximum of 60. And I find that if they are having more than 40, it means that they have the confidence to look after themselves or to make decisions confidently. If they are
mm,
less than 20 out of 60, it means that they don't feel they have the confidence and the knowledge and the motivation and even the opportunity to do it themselves. And the reality is, most people with chronic pain have a self efficacy score less than 20, which means that that coaching stance, that exactly as you said, having someone to hold them accountable or supporting them through their first few steps of the journey is very critical. And this is an evolving field. You might say, well, it might have to be a healthcare professional, but there is now an argument, or rather, there is now suggestion that having a lived experience or having a peer
mm,
support, having somebody who has gone through it themselves could be as effective or sometimes more effective than a healthcare professional, because when a patient is listening to somebody and that somebody hasn't been in their shoes, that person hasn't got chronic pain, that person hasn't got their life experiences like this person with pain has. For example, let's just take myself. If I were to tell a patient, oh, I think you need to reduce your processed foods and then you need to do this way, and I'll give you a tablet, but then you need to do about 5 minutes of activity, this particular activity there. And if I had a lived experience expert or a peer support alongside me who actually said somewhat similar things, mate, when I had this problem, this is what I did. I started with the lowest 2 minutes and I did this activity and I found that it was easier to do or could do. Then the studies and the feeling suggest that the patient is likely to look at someone who has been in their shoe themselves and listen to it and do it. So there is the reason I say this is that there are now lived experience people who are doing these pain cafes and peer support networks in different parts of the UK that are coming up, and they are able to show that they are providing that bit of support and emotional support and physical support and resilience to patients with pain, helping them move forward. So we as healthcare providers have got the opportunity here to not have to do all the work ourselves, but to find ways and build a system in which peer support can become also part of the standard of care.
mm. Nice. And I guess kind of moving off topic, but in terms of yourself, where you're working with all these patients and, you know, essentially, every day you have all these patients coming to you, talking about pain, talking about their experiences. I can imagine it being a somewhat toll to you as well. How do you, in that sense, manage your own kind of mental health, your own emotional well-being?
Really great question. And I think it is something that um, I've had to be very conscious about, because I did have that feeling of getting burnt out or getting exhausted around 2016, 17, when I felt, oh my God, the patients are coming back and what I'm doing is not helping. So around 2015 to 2016, I was feeling that kind of burnout where I felt I wasn't able to help my patients and do that. And more recently, last year as well, when the pressures of the NHS and everything got a little too much in terms of recovery from the pandemic, the waiting list and everything, I felt I was again not able to get to my patients that well. And when I was finding that pressure there, I could recognize some feelings of impact on my mental health. So I think first of all, being aware and recognizing that that can happen and being ready for it is quite important. Often people, especially healthcare professionals like us, we want to keep giving 110, 120% till we just fall off that edge. So I think that's very important to have that idea there. What I do is two things there. One, the actual process of trying to avoid that picture of burnout or exhaustion is I ensure that I use a variety of sport and activity. So I like running. In the last year, I've sort of found a group of other 40, 45-year-old Indian people who play badminton, who play tennis, and I've kind of tried to get myself out into groups wherein, and I don't talk medicine. I can just be another guy doing something and enjoying and doing that. So that's been my de-stressing activity. And of course, my family, my son is sort of finishing, coming to his A levels. Uh, so those are all the aspects of supporting, being there for the family as much as I can be. All of that keeps me in some ways grounded, or at least trying to change that. The second thing that's been a real game changer in my head is to realize that pain exists as a what's called a complex adaptive system, meaning that pain as a phenomenon is very complex. It is the end product of a variety of experiences and variables that are happening in our patients. They themselves are living in a complex system of society with various things that are affecting them, their work, the food they eat, politics, the society, various issues, ethnic minority, their backgrounds, everything else plays a part. Some of it are very visible and they will talk about it. Some of it is going to be dark and they won't be able to talk about it, nor will they volunteer it. And as an essential feature of a complex adaptive system is that there will always be unintended consequences, and cause and effect are not related. That means you can never be sure that you will find the reason for example, pain in a situation. That really takes a big load off my back when a patient sits in front of me in the clinic there, because I can tell myself I'm there to help them and walk alongside them that day. But there are always going to be things that I can never fully resolve. I'm not fully responsible for fixing them that afternoon in that clinic in 30 minutes. I can
Mm.
only do the best that I can with the information that I have, and I can lay the next one or two steps in their journey as they're going forward. The rest of it is not in my hands, was never in my hands, and I'm not going to be responsible for it. So that gives me a big release, because I just have to do that one good thing to that one person in front of me at that time with the information that I have. I don't need to beat myself up that I should do more or that I should be held to some other higher standard. And that has taken out a lot of the risk of burnout, because often I think we are at risk of burnout or moral injury because we feel we are being asked to do something that we're not ready for, or we're doing something and we've never been able to fulfill it to the standards we set ourselves that, we should sort it or fix it. I don't keep those two big things in my head right now when I see a patient in the clinic, and my all my thoughts are around listen to them, identify the one or two good things that they'd like to do. I can help, arrive at a mutual thing wherein I can do that help, and that really is the end of a consultation. That way I don't end up feeling upset with myself that I've not fulfilled something. So that way I've reduced a lot of the risk I feel of burnout in my own clinical practice.
Nice. I'm hearing a few things, I guess, from what you said. So one element is you're filling your own cup by doing things you enjoy, so the sports activities you enjoy. And it also
Yeah.
sounds like you've almost found your own kind of peer support community where you can be yourself and you can relax. And it's almost like it's not all about work when you're with them.
Yeah.
That's on one
Uh,
side. And then I guess with the other aspect, it's um and I guess it's something I'm also trying to learn to do is like setting boundaries. It's almost like showing yourself compassion and accepting that, you can't fix them in one go, and stepping back and being like, what can I do and move the needle forward for them in the right direction. And that requires boundaries in you not overstepping and not over helping, because that's going to burn you out. But it's also going to give, I guess, the patient in front of you the false expectation that actually maybe I can be fixed straight away.
That's the reality with any long-term condition, including chronic pain, is
Mm,
that in a weird way, the NHS 20 years ago was saying if you have a problem, go to your GP or speak to a doctor. Now, 20 years later, within half a generation, the NHS broadly is saying you need to do more to look after yourself. And all
mm,
long term conditions, including pain, it does mean, therefore, that there is a role that the patient also has to play in looking after themselves. We can only do so much. So, a lot of times, I realize that actually my role as a healthcare professional is to do the first step at least. Every interaction with me, I try to give them a little bit of confidence and hope that there are things that they can do for themselves. And so for me, I kind of set the mini challenge in my head with every patient is what can I say or do or help in such a way that they just improve their confidence and the hope that maybe that is the one thing they could try. And that is all I look for in a consultation. So I don't put myself out saying that I'll fix them exactly as you said, because that
mm,
raises sometimes expectations where they think that there will always be someone to fix it. But pain often is not like that. There are only parts of it that we can fix. Most parts, they will have to also support and help.
mm. You, I guess, similar to what I was just saying, there'll be times when you're stressed or you're tired or, things at home, arguments, whatever, are happening. And are there times when you're triggered, like in terms of, like, let's say you're with a patient and there's internal anger, internal sadness that are occurring at the same time? And how do you manage that in that situation where you're not projecting that onto the patient, or you're not allowing the patient to be project their own emotions onto you? Um how do you find that boundary? Like, how do you do it?
It's tough, Jack. That is
Mm,
tough. There are times when it has happened. I find predictably one is hunger. That
mhm,
makes me quite cranky. So closer to
yeah,
lunchtime, I can sometimes be finding myself that I'm short with patience. In a sense, I find myself that my reservoir of listening or empathy does reduce, and I tend to bring consultation slightly to a closer quicker. And I think that's been reported in literature as well. The same
mhm,
sometimes when I have this other issues, as you say, that occupy the mind there. What I try to do, most importantly, at least, is, and touch wood, thank God for that, is in the last 14 years as a consultant, there is that other part of me that makes me aware that I am setting a role model for my own team. So I try my best to never sort of lose my cool in front of the patient. That is,
mhm,
I have, it's almost like an internal system in me that I don't do that. What I find, and it has happened on two occasions where it has been very disturbing, I have told my nurse or the person there that I just don't feel right now. Can we reschedule the patient? Or
mhm,
I would just go out to, there's a garden nearby there. I would go along there for about 4 or 5 minutes, and I'd use, usually it'll be a breathing technique. Usually I try to use longer exhalations and shorter inhalations, so some kind of a 3-4-5 breathing technique, or a 5-5-5 box breathing technique, just to calm that down. Grounding, at least I would just sort of touch or feel something, because I'd be wearing socks and shoes, so I can't do that bit. So I just do that there. I might talk to my wife or my mom itself just to distract on there. So those are sometimes, and occasionally, if there is possibility, I would just go for a slightly longer walk around the hospital campus,
Hmm.
listen to some music or something that I can just take my mind away, and allow myself to calm down. And I think those are the usual 4 5 techniques I've done when things have gone beyond the point wherein I feel it might not be productive to my work itself.
Nice. You kind of answered my next question, which was, do you practice any relaxation techniques yourself? But you've answered that
Yeah.
yourself. So, um, I guess with your family, do they understand pain like you do? Like, do you explain that to them, or is there a level of like, I'm in pain, fix me, you're an expert?
I I'm blessed to the fact that my wife is from my medical school, and she's a couple of years my junior, so we've known each other for a long time. She's also a psychiatrist by background, so in that sense, she understands mental health and pain, and the overlap is something that we understand there. So she's been a big rock of support and understanding there. I think when it comes to my parents or the rest of my family members and my grandma, especially, those are really still tough conversations because when they do experience pain, which right now they are, they still hope that there will be something that can happen like that. And
Mm,
that is often a challenge because I don't have the answers there. And the conversations can be tricky. There's also the times typically like because both me and my wife we have a medical um, you know profession
but
with its
yeah.
responsibilities, with its vocational responsibilities there in terms of taking leave or going to India or being there for functions. We can't do that. We can't be there for everything that happens there because we've got jobs, we've got responsibilities here. We feel about our patients, and that sometimes is less understood because there's not uh, in my family there aren't that sort of medical profession, so they respect it, they understand it, it's taken time, they now are in a place where they understand, okay, fine, there are things that Deepak will do and won't do.
Mm,
But that is still in the early years of my time in India and coming here, there were those expectations that I would be still doing everything, but obviously not possible. It's been a change. And I think education wise, they are still of the belief that everything can be fixed by healthcare and you can swipe right or left. And in India, within 24, 36 hours, you can get scans or you can
mm,
get supposed answers and quick fixes. So there's always that expectation that I would also come up with something similar.
mm. Okay. Um, One question that I always ask on this podcast is, what does it mean for you to be a South Asian man? Um, so yeah, for you, from your experiences, what does it mean for you to be a South Asian male?
I think two parts here. For first of all, being a South Asian man, a first generation immigrant in this country, is being aware that there are responsibilities. There's still that community expectations, both back home and here, on what I, as a South Asian, would need to do, both in terms of responsibilities to my immediate family, to my in laws, to my parents. And I think that's something that is almost a conventional view that I can't break away from. So that's something I have to be aware and deal with. And I'm coming to that stage now wherein I'm the single sort of the eldest son.
Mhm.
My sister is in the US. So if there is an expectation somewhat that I would be there for my parents when the time arrives and if the time is arriving there. So that's something that I am very conscious of in terms of the cultural thing. I think the other thing that I'm aware of, in again with reference to the UK, is there is an expectation that as a Asian immigrant, an Asian living here, there will be some stereotypes that will be placed upon me as to what I bring to the table. As you know,
Mhm.
yes, he's Asian, he's Iban, he's got to be this and that and that.
Yeah.
And that is an advantage sometimes with some of my friends who say, okay, fine, yeah, Deepak will sort this. But that also is a disadvantage because it means that I'm boxed into some unknown stereotype which I may not necessarily fulfill or ever be part of, but I won't know it until I actually asks that person, what do you think you want from me with this image that you have of me? And
Mm.
I think those are examples. I can't think of any ready examples now,
Hmm.
but I'm sure that there will be some things that happen in the future wherein both these aspects will come to light there. But other than that, really, I don't know if that kind of answers your
It
question
does,
there.
yeah, yeah.
Uh, Other than that, really, the biggest thing that thanks to so many of, for example, your parents and who might have come here and you've grown up here, I found it much easier. The various other things that you've heard about 1960s or 1970s Britain in terms of how ethnic minorities were uh, subjected to various forms of treatment, at least I did not have to feel that in my time here in the UK.
Mm.
Partly maybe because I was in the medical field, so there was a little bit of that respect factor there. But I think a lot of struggle has been had by the people who have been here from 60s and 70s, and they've made it so much easier for my children, for me, and so many of my people who are, our people who have come here in the 90s, 2000 onwards.
Nice. It's one of my last questions, but um, having, I guess, your background, having your experience, your expertise to the point where you are now, do you feel a level of responsibility to educate people about pain and changing how pain is approached? Or is it more so a passion that you have that you're kind of just like, okay, this is how I understand pain and this is a message I want to get across and this is what I'm going to do? Or is there also a level of like responsibility where you're like, actually, I have to do this because not everyone understands this, and this is my own understanding that I need to get across.
Great question. I guess so.
Yeah.
And I did my sort of management training a couple of years ago in Henley Business School. And there I came across this Japanese word, and these Japanese are really great at having nice, posh words that explain everything. So
Yeah.
there's this word called ikigai, and
Mm.
and ikigai is that central uh, place of being of a person where they have found this unique middle ground of four things, things that you're good at, things that the world needs, things that you have a passion for, and things that people will pay you for. If there is something that is at the intersection of these four things, then that means you've got your ikigai, in a way, your reason for being. And for me, that ikigai is really that pain science education. I found that this is something I'm passionate about. I'm also good at. It's something that I feel very strongly the world needs. And yes, if people pay me for it, then that is all the more reason for me to continue doing it there. The other, so that's so because this is my ikigai, I don't think of this as a chore or a job or a work. I just feel that this is something I love doing and I would be happy to do for the foreseeable future. There is a second part linked to it, is this concept of trauma informed care, the
Mm.
understanding now that what happens if the pain experience that I told you about is a phenomenon of the nervous system remembering memories or remembering events from before, and has got these predictions of protection built into it. Then the nervous system and the immune system can be impacted by a variety of other experiences that go through the life. It can be adversity in childhood, it can be trauma, it can be abuse, it can be neglect, it can be bullying, it can be anything in the adulthood like loneliness, isolation, divorce, road traffic accidents. Now, all of those traumas that will change the nervous and immune system need to be recognized about, because I feel very strongly that if we understood that properly and made a societal effort to raise awareness and address that at policy level, at political level, at government level, at local authority level, then that should address some of the sustainability and the cost of medications and overdiagnosis that we are right now doing in the NHS, and for that matter in Western healthcare everywhere. Now, some things may be difficult to change, but for me, I feel that that kind of trauma informed raising awareness, pain science education is something that should be at public health and policy level. And for me, I feel, well, you know what? I'm in a complex adaptive system. My role is to just keep seeding these. I do not know which set of combinations will result in a change of policy that
Mm,
is going to go in the direction. But my role as a responsible provider now, having found my ikigai and found this, it is very much my responsibility to keep talking about it, keep finding small seeds, keep sowing seeds here and there, talking to people like yourself on your podcast for your listeners, because each of this, I do not know where the little final domino that pushes everything and something will happen. We do not know, but that doesn't mean I should not try. And so that's what
mm.
keeps me going. And I feel that as long as I have that curiosity and trying attitude, I don't have anything to lose.
Nice. I like the answer. Thank you for coming on the podcast. We normally finish with like a checkout. So, um, any final words that you want to share? Anything that you feel the audience will benefit from?
No, I can't think of anything, but you need to tell me if there's anything that your audience would feel they want to know a bit more,
Hmm.
then absolutely. Otherwise, if your audience wants to know a bit more about pain or myself, I'm there on other social media channels, so they can find me by Googling my name in, and hopefully you'll have some things on your podcast show notes as well. But do you have any questions for me? Anything that you feel you would want to ask?
Right now, no. I'm very happy with how it's gone, and thank you for all the questions that you have answered. I will post all of your details down below, but I guess if there's one platform that you're on the most, is there a platform that they can reach you on?
Uh, For the speaking side, if they are interested in that part, they're LinkedIn. Otherwise, for other understanding is my YouTube channel.
YouTube channel. Perfect. I will post all the links down below. And yeah, thank you for coming on. Hopefully, in the future we can come on again and we'll invite other people as well. But for now, thank you.
Love to have you. Thank you for having me once again, Jack.
It's been a pleasure. Thank you.